So then NABH has given us indicator to monitor. हमको क्या मॉनिटर करना है जब हम NABH इम्प्लीमेंट करते हैं ना, तो अभी हमारे पास SOPs है, हम इंडिकेटर्स मॉनिटर करना शुरू कर देंगे, हमारे पास सिस्टम्स इंप्रूवमेंट होंगे। तो हाउ इट इज द आउटकम ऑफ आवर इम्प्लीमेंटेशन इज मॉनिटर्ड बाय कॉल की परफॉर्मेंस इंडिकेटर। तो हमारा भी इंडिकेटर जब होता है एज अ ह्यूमन, हमारा परफॉर्मेंस अप्रेजल होता है ना, दैट एवरी ईयर वी गो अंडर परफॉर्मेंस अप्रेजल। तो सेम हमारे यहाँ 32 डिफाइंड मैंडेटरी क्वालिटी इंडिकेटर्स है जो NABH ने मॉनिटर करने के लिए बोले हैं। तो हम एक एक करके देखेंगे वो क्या है। ये ऑल डिपार्टमेंट के लिए होगा, क्लिनिकल डिपार्टमेंट एंड नॉन क्लिनिकल डिपार्टमेंट। तो पहला इंडिकेटर जो है ये आता है PSQ चैप्टर, तो पेशेंट सेफ्टी एंड क्वालिटी जो चैप्टर है उसके अंडर आते हैं सारे इंडिकेटर्स। तो फर्स्ट इंडिकेटर्स जो NABH कहती है वो कहता है टाइम ऑफ इनिशियल असेसमेंट ऑफ इंडोर पेशेंट्स। तो टाइम ऑफ असेसमेंट क्या कहता है, उसका न्यूमरेटर और डिनोमिनेटर हमें देखना है, और इट इज यूनिट ये मिनट्स में कैलकुलेट होगा। तो सम ऑफ टाइम टेकन फॉर असेसमेंट अपॉन टोटल नंबर ऑफ पेशेंट एडमिशन। तो इसको हमको सैंपल लेना है, हम कितना परसेंट सैंपल लेंगे पूरे एडमिशन का, तो वो होगा। तो हमारे पास ऑन एन एवरेज इन अ मंथ कितने एडमिशंस होते हैं, मे बी 5,000, 3,000, जो भी है। सपोज लो ऑन एन एवरेज 3,000 पेशेंट्स गेट एडमिटेड पर मंथ, तो उसका सैंपल साइज होगा। तो बेस अपॉन दिस इनिशियल सैंपल साइज दिया है, बट दिस इंडिकेटर इज फॉर इनिशियल असेसमेंट। तो इज वेरी इंपॉर्टेंट, जब पेशेंट एडमिट होता है तो वी डिफाइन कि विद इन अगर क्रिटिकली इल पेशेंट है तो विद इन 1 आवर डॉक्टर्स हैज टू सी द पेशेंट व्हेन ही और शी गेट्स एडमिटेड इनटू द हॉस्पिटल। ओके। अगर रूटीन एडमिशन है, जैसे सर्जरी है, प्लान्ड है, इलेक्टिव सर्जरीज है, दैट कैन बी असेस विद इन 24 आवर्स ऑफ द असेसमेंट ऑफ द एडमिशंस। तो वो उसका सम ऑफ द टोटल सम ऑफ द टाइम टेकन फॉर असेसमेंट, तो सम क्या हो गया। तो फॉर एग्जाम्पल एनी वार्ड लेकर, जैसे मेडिसिन वार्ड लिया, मेडिसिन वार्ड में सपोज 100 पेशेंट मंथली एडमिट हुआ है, तो उसका सम। तो जैसे जैसे टाइम ऑफ एडमिशन हम इसको कैलकुलेट कैसे करेंगे, तो टाइम ऑफ एडमिशन, सपोज सपोज पेशेंट इज एडमिटेड एट 1 PM इन द वार्ड, वार्ड में 1 PM पे आया और डॉक्टर ने उसको 1:15 पे असेस किया, बिकॉज डॉक्टर नोट्स में भी पुट द टाइम ना, टाइम ऑफ सीन, डेट, टाइम एंड सिग्नेचर। तो वो टाइम उस टाइम से मैच होगा, तो वहां से आपको टाइम ऑफ इनिशियल असेसमेंट मिलेगा। मतलब ये जितना आसान है उतना दिखता नहीं, यू हैव टू अंडरस्टैंड फ्रॉम वेयर यू विल गेट द योर न्यूमरेटर एंड वेयर यू कैन गेट योर डिनोमिनेटर। ठीक है, तो हमें न्यूमरेटर तो सम करने के लिए बोला है, सम मतलब हम टोटल निकालेंगे। सपोज 100 पेशेंट्स है और हमने देखा कि हमने सैंपल्स 100 पेशेंट, हमने 10% सैंपल लिया, तो 10 पेशेंट का हमने मंथली कैप्चर करना शुरू कर दिया ओनली इन मेडिसिन वार्ड्स। तो वैसे हमारे पास n नंबर ऑफ वार्ड्स है, तो अगर उनमें से सब में से आया तो हमें पता चलेगा कि इस वार्ड में इसमें से इतना स्टेबल और इलेक्टिव पेशेंट है, और जो भी पेशेंट है उसमें विद इन 10 मिनट्स या 15 मिनट इस डॉक्टर असेसमेंट अपनी कंप्लीट कर लेता है। So that is the concept of the NABH. Why this indicator is giving that within the stipulated time the patient has to be seen by the doctor on the floor. ठीक है। So this is for lab and radiology. सेकेंड इंडिकेटर नंबर ऑफ रिपोर्टिंग एरर पर 1,000 इन्वेस्टिगेशंस। तो हमारे कितने इन्वेस्टिगेशन पर 1,000 इन्वेस्टिगेशंस पे रिपोर्टिंग एरर। अब ये रिपोर्टिंग एरर क्या हो सकता है नो, फर्स्ट वी हैव टू अंडरस्टैंड हमें कैप्चर कैसे करना है, ये कैसे कैप्चर होगा। कैन यू सी ऑन दिस साइड। तो दिस इंक्लूड्स रिपोर्टिंग एरर पिक्ड अप आफ्टर डिस्पैच। अब कौन से एरर है जो आफ्टर डिस्पैच हम कैप्चर करेंगे, ट्रांसक्रिप्शन एरर्स। ओके, मच बेटर। So only for lab and diagnostic. I can say for diagnostic, who gives the report. So what are the errors? Transcription. Okay. Transcription errors में क्या हो गया? Values, report, name, ward number, जो भी आपका ट्रांसक्रिप्शनल एरर है वाइल प्रिंटिंग या जो भी है, वो एरर हो गया और आपको रिपोर्ट रिट्राइव करना पड़ा, सो दैट इज वन ऑफ द एरर। तो आप इसको पहले तो कैप्चर कैसे करेंगे, वहीं से शुरुआत होती है जहां से हमें ये डेटा मिलेगा। सो हाउ डू यू कैप्चर दिस एरर? तो फर्स्ट ऑफ ऑल आपको यहाँ पे एक रजिस्टर या एक एक्सेल शीट मेंटेन करनी पड़ेगी एज पर योर कन्वीनियंस, हाउ यू कैन कैप्चर दिस, है ना। तो उसमें से हमको एरर लिखना पड़ेगा। तो एरर क्या होगा इसमें से, फिर आपके स्टाफ को आपको बताना होगा कि अगर ये इसमें से कोई भी एरर हुआ तो वी हैव टू कैप्चर इट। तो कैप्चर में क्या लिखेंगे हम, पहले तो डेट, फिर टाइम, व्हाट वाज द इंसिडेंस और व्हाट इज द एरर दैट हैपेंड, नाउ हु अटेंडेड इट, ओके, एंड व्हाट वी डिड फॉर दैट। तो यहाँ से आपका मंथली डेटा आना शुरू होगा, ठीक है, यहाँ से। तो ट्रांसक्रिप्शन एरर ये हो गया है। रिपोर्टिंग एरर तो हमारे पास रिपोर्ट पे होता है एक तो पेशेंट के डिटेल्स, उसमें कोई एरर हो गया वो, उसके बाद हमारे होता है हमने जो एनालाइज किया है या तो सैंपल्स जो भी है, उसमें अगर कोई रिपोर्ट राइटिंग में हमारे पास कोई एरर हो गया है आफ्टर डिस्पैच और बिफोर डिस्पैच एंड वी रेक्टिफाइड इट, दैट वी कैन कैप्चर इट, ओके। So that will be your total number of reporting errors in that month. And this is all monthly basis. And then your denominator में total number of tests performed in that particular thing for that particular month into 1000. तो आपके जितना भी आपका आएगा वो आपका उस महीने का इंडिकेटर होगा, उतने एरर्स होंगे उस मंथ के लिए। Now, third is percentage of adherence to safety precaution by staff working in the diagnostic. Now, it is called percentage of non-adherence नहीं कहा है, it is called adherence, ठीक है ना। This is also monthly. Now, what is adherence और हमें safety? So this also this is again for diagnostic department. तो आपको एक ऑडिट करना पड़ेगा, ठीक है ना। तो ऑडिट करने के लिए आपके पास एक चेकलिस्ट होनी जरूरी है। चेकलिस्ट में आपके पास टिक टिक ऑप्शंस होंगे ऑप्शनल कि हमको क्या करना है। फॉर रेडियोलॉजी फॉर एग्जांपल, अगर हम एक्सरे में कर रहे हैं तो एक्सरे में रेडिएशन सेफ्टी मेजर्स क्या होने चाहिए देखते वक्त। सो द पर्सन वाज वेयरिंग द टीएलडी बैज, द पर्सन वाज वेयरिंग द लीड एप्रन और द थायराइड और द गॉनोइडल, जो भी उनके जो सेफ्टी मेजर्स है वो टिक है। पेशेंट हिस्ट्री वाज टेकन। So you have to just make 3, 5, 6 जो भी 10 पॉइंट्स है चेकलिस्ट लिस्ट के, उसके बेस पे ये ऑडिट होगा। और इस पे आप सैंपल कीजिए। तो आप पे सपोज आपके 10 स्टाफ है, आपने 10 स्टाफ का ऑडिट किया, दिस इज वंस अ मंथ दिस थिंग एक्सरसाइज। अगर मंथली आपने किया, सपोज 10 स्टाफ को आपने ऑडिट कर लिया, तो उसमें से 10 में से सपोज 5 वेर अडहरिंग टू ऑल द सेफ्टी प्रिकॉशन दैट इज नीडेड in the lab or in this thing. So there will a number of staff adhering safety precautions. So we have write 5 and we have audited 10. So 5 upon 10 into 100. तो अपना परसेंटेज आएगा। तो दैट मीन्स दिस मच परसेंट ऑफ द स्टाफ वाज adhering to the safety precautions for that month. Now this is medication error. This will be pertaining to all the departments. And who should capture this? Who will be recording this? Nurses and the doctors in the respective wards, and where all the medicines are given or administered to the patient. So medication error is an obviously it is a preventable error which we have to have. So now what is the total number of medication error upon total number of opportunities? Now what are the opportunities you understand? Suppose there is a paracetamol prescribes 1 TDS for 5 days. Okay. So 1 TDS for 5 days. So how many opportunities are there? 15. Okay. Now the error happened. Suppose it is on the second day on the afternoon dose. So first 3 doses gone, morning dose has gone. The error had happened in the second day afternoon dose. Okay, so the what will be the opportunities left then of the error happening? 3, 4, 5 and 10. So you got it. How do you calculate the opportunities? तो जिस दिन एरर हुआ, जिस वक्त एरर हुआ, उसको छोड़ के बाकी कितनी अपॉर्चुनिटीज है उसका कि इस मेडिसिन के एरर होने के चांसेस कितने हैं, दैट इज द टोटल अपॉर्चुनिटी यू हैव टू कैलकुलेट। हाँ, तो वो होगा। सो उस मैंने टोटल नंबर ऑफ एरर अपॉन टोटल नंबर ऑफ अपॉर्चुनिटी, देन यू कैन सबमिट ऑल द अपॉर्चुनिटीज डिपेंडिंग अपॉन द एरर दैट हैपेंड इनटू 100, फिर वो हमें परसेंटेज देगा। नाउ व्हाट आर द मेडिकेशन एरर्स? मेडिकेशन एरर्स क्या हो सकते हैं? रॉन्ग एडमिनिस्ट्रेशन, रॉन्ग ड्रग, रॉन्ग डोज, रॉन्ग रूट। मेडिसिन के रिलेटेड कुछ भी चीज है जो होनी चाहिए और नहीं हुई, दैट इज मेडिकेशन एरर। सो ड्रग, डोज, रूट एंड टाइम और omission. Suppose the doctor has advised any antibiotic to be given at 10 a.m. to the patient IV, but the patient has not received the dose at 10 a.m. through IV or totally omitted, or this thing will be come as a medication error. Then why medication error happen? Everything that will be another thing. But first thing is how to capture the numerator and the denominator. Okay. Now is percentage of inpatient developing adverse drug reaction. Now what are adverse drug reaction? Any prophylactic or any reaction that patient counters with the any administration of, even it is with the contrast also, we have to capture. So number of patient developing adverse drug reaction, could it be a rash, um, any this thing that happened when the medication was administered has to be reported, and total number of inpatient into 100, so that will give us the percentage. This is also for the contrast. Now this is only for the OT. So unplanned return to OTs. Now how we calculate the unplanned return to the OTs? So unplanned return will be always those which are either not in the OT list, not are elective, and those are, this is not the emergency one, because emergency one also unplanned, but they call return. So any complications of the previous surgery, patient coming back to the OT is unplanned return to the OT. That's what the definition also says, as a secondary procedure required for the complication resulting directly from the index operation during same administration. Post-op bleeding, debridement, any resuturing, anything that you feel is there, and a patient has come back to the surgery operation theater. So in that month, total number of unplanned return to the OT, and upon total number of patient who underwent the surgery in the OT into 100 will give you the percentage of unplanned return to the OT. So how this can be captured? In the OT, we can have a indicator register or the Excel sheet, whichever is easier and convenient form for you to maintain. So date, time, what was the surgery, which was the department, who was the surgeon, what was the case, and what was the complication for which the patient has was wheeled in back into the OT. Percentage of surgeries is where the organization procedure to prevent adverse event like wrong site, wrong patient, wrong surgery have been adhered to. Again, this is a positive indicator, not a negative one, where we have adhered to all the things which prevents this is asking. So number of surgery where the procedures was performed and the number of surgeries that were audited. Same thing into 100 will give you the percentage. Now this is again a checklist and audit based indicator where we can have the what will be the parameters that will be audited will be defined in the audit checklist. So what are the things that we prevent surgeries from having wrongness? First is identification. So do the patient have proper identified, the tagging is there or not, or site marking is done or not, or safety WHO safety checklist is filled or not. So these are 3-4 parameters for which we check which prevent us from having this incident happening in the organization. Percentage of transfusion reaction. So this is Number of transmission reaction upon total number of unit transferred is a direct indicator. Into 100 will give us the total number of transmission reaction happen in the for that month. This is for all the ICUs. Standardized mortality ratio, actual death upon predicted death. And how you calculate the predicted death? Anybody from intensive care unit? So you have the Apache and the SOFA score. From that, you get that you are denominated the predicted death in the ICU. That's how this indicator will be calculated by the intensive care unit. Then it says return to ICU within 48 hours with the same complaints. Now, if you have discharged the patient of the ICU and patient has come back to the ICU within 48 hours, so that you will have to capture upon the number of discharges or transfers done from the for the total month. This is all our monthly indicators. Is when it will give you the return of ICU within 48 hours. Again, you will have to maintain a Excel sheet or indicator who will to capture this. Now, as it says unplanned return to the OT, returning to the ICUs, and it says now returning to the casualty or the emergency department. Now it says within 72 hours. The OT was for in the same admission. 3 days 5 days में वापस पेशेंट आ गया तो कैप्चर करो. आईसीयू के लिए कहता है विदिन 48 के लिए करो, और कहता है 72 आवर्स में अगर कैजुअलिटी डिपार्टमेंट और इमरजेंसी डिपार्टमेंट पेशेंट वापस आ रहा है विद सेम कंप्लेंट. सपोज पेशेंट आया था पेन इन अब्डोमेन के लिए एंड अवर वी चेक एंड गिव मेडिसिन और वॉट एवर करके पेशेंट को हमने ओपीडी से डिस्चार्ज कर दिया. बस 72 आवर्स में पेशेंट वापस कंप्लेनिंग with the pain in abdomen आया, then we have to capture it. अगर same patient with headache से आया तो we don't have to, okay? But अगर same complaints कहता है some complaint, अगर fever से आया है तो again he came for the fever for the same complaint, then we have to capture. So how many times or how many patient has come? So that is the number of return to emergency within 72 hours with similar presenting complaints upon total number of patient visited to the casualty in that month into 100 will give us the percentage of return to ICU, I mean emergency department. Now, incidence of hospital acquired infection. I mean ulcers. Anyone from nursing this side? Because this is a nursing indicator. नहीं है ना? So pressure ulcer और bed sore जितने भी patient के हुए हैं उनको total number of patient upon total number of patient days calculate per 1000 करना है. Now I see infection control. So these are infection control indicators. Catheter associated urinary tract infection. So number of catheter associated urinary tract infection in that month upon total number of catheter days per 1000. So this is as per the CDC guidelines and definitions. Same goes for ventilator associated pneumonia. So number of ventilator associated pneumonia in a month upon total number of ventilator days in that month. Central line associated with bloodstream infection rate. Number of central line associated bloodstream infection rate infection in the month upon total number of central line days in that one into 1000. Now it is surgical SSI, that is called surgical site infection rate. Now this is within the hospital days when the patient is, if patient has fever, oozing or pus formation or what, anything, and we capture and we report to the infection control nurse or infection control officer that we have. So patient, they will come take swab or whatever as per the protocol they did. So then we have to address this patient as our surgical site infection unless and until they are diagnosed with the help of laboratory evidence. And this also we have to track for implants. Now implants will be in ortho, cardiac, and sometimes in ENT and ophthalmic. So all these cases and wherever necessary is there, the implants. So implants will be for 1 month. We'll have to take the follow-up to see whether there is any surgical site infection. Upon total number of surgery performed in that month into this is 100 will give us the rate. So this will show us where is our how much we lies in our surgical site infection rate per month. but capturing is important. So we have to capture this. Then only we will get a correct numbering or the indicators happening to us. Compliance of hand hygiene practice. This is done by the infection control nurse, assigned infection control nurse, who goes and do this is again an audit and observation based indicator capture, that is total number of action performed upon the opportunities of hand hygiene. Now this is anesthesia. Percentage of cases who receive appropriate prophylactic antibiotic within the specific time frame. Now, what is the time frame of giving antibiotic for the surgical patient? Before incision, after incision? Anybody from anesthesia, surgery, ortho, ENT, ophthalm? Which? Ophthalmology? Ophthalm is okay. So you have eye drops, no? Anybody from ortho, cardiac, general surgery, anesthesia? So generally within 1 hour or 30 minutes of the incision, the administration of appropriate antibiotic need to be given to the patient as per the CDC guidelines. So this again is a positive indicator ki how many of our patients has received the prophylactic antibiotic within the stipulated time upon the number of patient underwent surgeries into 100. Now, percentage of rescheduling of surgeries, so these are managerial indicators which talks about the utilization of the OT. That's why the rescheduling of surgery comes in. So once we start capturing, there are root cause analysis. That's the entire process that goes upon. First, I will explain you the indicators. Okay, we'll come to that point. So rescheduling of surgeries includes any cancellation, postponement of the surgery beyond 4 hours. And so how many times in a month, a particular doctor or particular unit has cancelled the surgery or rescheduled, after 1 hour, after 1 days or 2 days upon the total number of surgeries that was planned. Now, these are all for planned, not for emergency. Into 100 will give us the rescheduling of surgeries in the particular OT. How many total OTs we have? Nobody. This is for blood bank. Turnaround time for issue of blood and blood components. So sum of time taken upon total number of blood or per component cross match or reserve. Sum of time taken for the dispatch. So when the request come to the blood bank from any of the ward or the floors and it goes to the blood bank, and within how much time the blood was issued to the floors or the ward is what we capture. So turnaround time is in the emergency like ICUs, cardiac OTs, within how much time, with cross matching and without cross matching, the blood reaches to the point is what we look into this. This is a blood bank indicator. This is a nursing indicator, nurse patient ratio. This is again a managerial indicators, waiting time for outpatient consultation, how much time the patient waited to see upon the total number of patients visited the OPD. This is for diagnostic. Sum of time taken upon number of patients reported in the diagnostic. Now it will be the diagnostic requisition form being presented till the time is till the time the initiated. The modality has been initiated to the patient will give us the sum of total time. Time taken for discharge. Now, sum of time taken for discharge upon total number of discharge. This is also minutes. Now, sum of time taken for discharge is when the consultant writes the patient can be discharged. From that time when the patient is actually physically discharged from the ward is what is the time taken discharge we calculate. Okay. Percentage of medical record having incomplete or improper consent. This is a medical record audit, this thing. So number of medical records having incomplete or improper consent upon total number of discharge or death into 100 will give us the appropriate figure of how many of the medical records were having incomplete or improper consent. Now consent is the thing which has a medical legal this thing. So a request to all the consultant and the doctors to have please completely fill your informed consent. So this is stock out of emergency medications. So this will be from your stores or where they're actually the storage of pharmacy or dispensary water. So number of stock outs of emergency drugs. So how many times there was a stock out of emergency drugs? Not this talks about only schedule of emergency drugs. Variation of mock drills. Now this will be new to the you all that we have codes, codes were initiated like code red, code blue. So now all the codes need to undergo a mock drills. Now what are mock drills? Mock drills can be actually conducted in the hospital or it can be a tabletop. Generally disaster is a tabletop, fire is a tabletop. Rest all can be actually performed on the floor. Now which are the actually can be performed on the floor are code orange, code blue, code white. What are the code whites? Code why the code red and white are same, so that there is no chaos or panicky situation between the visitors or the patient that is in the hospital, because they will not understand the code language that we say. That's why universally this codes has been given. Like code red is for fire. If there is any major or minor fire breakout in any of the floor of the hospital, then the code fire has to be announced. And why it has to be announced? Because we need help, huh? To extinguish the fire and let our staff, ourselves, and our patient to be safe. For the safety precaution. That's why the codes are there in place. Now, when we do the mock and while doing the mock, we monitor or record the variation that happened in the mock. Suppose if we are doing code red and the team did not reach on the floor on time is one of the variation. Now, why the team did not reach on the floor on the first time is the thing that we need to see why there was a variation, why. So why? So when you collate all the indicators and decide, so there are committees where this four indicators will be discussed. The first apex is quality committee where this will be discussed all, and there are various committee that will can come back to the committees where these indicators will be discussed and seen into more detail why the things didn't happen as it was defined and what was the solution that they can provide. Incidence of patient fall. Now, whatever anywhere in the organization, whether it's an OPD or IPD or OT, patient fall has to be captured. So total number of patient fall upon total number of patient days. Near miss. Now what is near miss? So near miss is an any event which did not harm the patient or the staff, but it could have harm, and there was a prevention that happened before the harm was this. So the definition says that near miss is an unplanned event that did not result in the injury, illness, or damage, but had the potential to do so. Now, for example, what it could be? Suppose somebody is walking here, okay, and this floor is little bit near this thing, or the what do you call gas cylinder or fire extinguisher is keep, and somebody tripped over it. You know, before tripping, somebody noticed there is a fire extinguisher in place. Let me keep it aside, or somebody will fall. So now this was a near miss. If somebody were to open the door, he would have done a fall. So we capture. Or what is the clinical indicator is indication we can say. Suppose there was an IV lookalike sounder, like any lookalike sounder, like medicine name you can tell, any injections or any medicine which is high risk. जो दिखने में भी सेम है यहाँ पे, बिकॉज यहाँ पे बहुत सारी जेनरिक मेडिसिन भी आती है। डोपामाइन और डोपामाइन यू से इट साउंड्स अलाइक। अगर इफ यू हैव सेंड डोपामाइन हैज टू बी गिवन and they were picked up some other vial or ampule, and the nurse, of course the nurse has to check, you know, ki whether this is there or expiry or that, but still, you know, some wrong ampule was taken, and the second sister let me check, or the doctor said let me check what you are giving, and they found that it is an expired medicine. So it was a near miss, you know. The staff was happened to administer the medication, expired one, but somebody, you know, the second one, or she herself has noticed that it is not, it is expired, so I should not be. So that was the event that was prevented. So that is called the near miss. Now this is extremely, I can say, presence and of mind has to be there by capturing this indicators. I know most of the time there will be many of the incidents where in you may be that, you know, कुछ होते होते नहीं हुआ है ना, होना होते होते आपने बचा लिया है. So that is how the near miss will be reported, है ना, upon the total number of incidents reported. So what is the total number of incidents reported? So what is the incidents? First of all, incidents is any untoward event that happened into the system or the organization which should not be happening is called the incident. Very simple. उसमें ये सारे आएंगे, जैसे आपका मेडिकेशन एरर आ गया, ब्लड ट्रांसफ्यूजन हो गया, वो इंसिडेंस हो गया, पेशेंट फॉल इंसिडेंस है, स्टाफ फॉल इंसिडेंट है, किसी को शॉक लग गया वो इंसिडेंट है. ये छोटी छोटी बातें होती है ना, भाई प्लगिंग प्लग डाल रहे हैं हम, पेन से डाल रहे हैं, पेंसिल से डाल रहे करके प्लग लगाते हैं, उसको करंट आ गया. सो दैट इज ऑल्सो एन इंसिडेंट. हम ओवरलुक करके छोड़ देंगे तो नहीं चलेगा, क्योंकि दैट इज द पोटेंशियल टू कॉज फायर. Okay, so we will not neglect small things. So that is called incident. वो नहीं होना चाहिए ना, somebody is plugging something and they have the current, तो वो नहीं होना चाहिए. तो वो सारे incidents होते हैं, हाँ. वो incidents वो हो चुके हैं, incident it has already happened. but जो incidents नहीं होने वाले थे और आपने बचा लिया is the near miss. ठीक है. नीडल स्टिक इंजुरी, इसका प्रोटोकॉल सबको पता है, हमने पूछा भी था. एवरीबडी नोज वेयर टू गो, व्हाट टू गो. Even doctors know about needle stick injury policy. हाँ या ना, मालूम है ना. सो अभी इस क्राउड में से कितने, हाउ मेनी हैड नीडल स्टिक इंजुरी इन लास्ट 3 months? None? Last 6 months? Then this, or either it is not reported, either of them. The nursing has to be last. So kindly report the needle stick injury, whether you are operating or performing any procedures. It need not be only while giving injections. Huh? Any type of sharp injury has to be reported. Handovers. This is for nursing and for the doctors. What is your handover procedure? Just for my information. Is there any formal handovers? No, no, no. So this is overall a generic problem for entire hospitals. Huh? But nursing has a very process, handover process. So lab, yes. Compliance rate to medication prescription in capital. So this is the last indicator that talks about NABH. And are we adhering to it? Just give a frank a reality, let me know. So total number of, now this has been be captured by the clinical pharmacologist or the pharmacist at the end, where the indicator, I mean the prescription goes in, not basically for the indoor patient as such, but this is all for the OPD patients. With my view, all prescriptions are computer generated, or still there are handwritten. And so if it is computer generated, the concept I'm telling is what even our this things is that it has to be prevent medication error. So now IP we can understand, but the OPD patients, if they are taking wrong drugs or, wrong strength has been given to them, we will not know unless the patient comes back for the follow-up and we see what the patient is taking. So that prevent medication error to the patient and to go the wrong medicine, the capital, it has to be readable. The pharmacist should be able to read the prescription of a doctor. That's why this has come in. The compliance is by doctors. Who will check it is there. So check-in will be done by the wherever the prescriptions goes. Suppose you have written your prescription, you are taken to the patient, and patient as I'm a pharmacist or whoever is dispensing, it comes to me. Okay, so then I will check whether take a sample of the audit whether we have the prescription or not. Capital letters. It is talking about capital letters, not error in the prescription. So error in the prescriptions will be, that is the audit that will be done by a pharmacologist for inpatient. Therapeutic duplications, unapproved abbreviations, BD, TD, वो सब वो करेंगे. So this is only adhering to the capital letters. So these are 32 indicators. Adverse events.